Floyd, thanks for arranging this. It's nice to have a little break from COVID-19. And, I'm as interested as everyone else about the content lineup here that you've lined up. And so hello to everybody from around the United States and around the world. Floyd asked me to give a talk. He pretty much left it up to me of what I wanted to discuss. And so I selected post-resuscitation care, or how to turn ROSC into survival. Because as much as I believe that return of spontaneous circulation is a really important benchmark, obviously it's not the goal. Our goal is a neurologically intact survivor being returned home to their families. And so that's what I wanted to talk about today. If you're not familiar with Hilton Head Island, which is where I'm from, we're a barrier island off the very southern coast of South Carolina. And according to census data, we only have about maybe 42,000 people here, but in reality, we see about 2.5 million visitors a year in our peak summertime population, especially when Easter lines up with Heritage Week, because we're a stop on the PGA Tour. Our local population can swell up to about 250,000. So we work about 50 active resuscitations a year, and we've been in the CARES registry for about 10 years. So we've been very successful with out-of-hospital cardiac arrest on Hilton Head Island, and a large part of that is that we have implemented many of the core strategies of the Seattle-King County Resuscitation Academy. So number one, we have the Cardiac Arrest Registry, CARES, which we've been in. We were the first in South Carolina to report data to CARES. And we've always practiced rapid dispatch. So in other words, we're a department that likes to get the first unit out the door within about 60 seconds, regardless of complaint. So we don't wait until pro QA, until we're completely done with all the emergency medical dispatch questions. We try and get the first unit out the doors as quickly as possible. Telecommunicator CPR. We were early adopter of RQI's RQIT product, which we started to implement this year. So we're giving enhanced training and support to our telecommunicators to be able to rapidly identify sudden cardiac arrest and to give them the tools they need to rapidly give those CPR instructions on the other end of the telephone, so that we actually have chest compressions happening prior to EMS arrival. We've had a long-standing public education where we train about 500 people a year in bystander CPR, and we know where all of our AEDs are, and we implemented Pulse Point last June. And then finally, high-performance CPR, which honestly is like religion here, from top to bottom in our organization. So we're very grateful for our long-standing relationship with Seattle-King County. You really won't find a more knowledgeable, more generous, and more humble group of people, I think, in the world. We've just learned a tremendous amount from them, not only about cardiac arrest, frankly, but also we were very, very grateful to their support to help us dial up our policies and procedures for COVID-19, because they were one of the first in the nation to deal with that problem as well. So this is what Mickey Eisenberg refers to as the slope of death. And so the old dogma that for every minute delay in defibrillation, odds of survival go down about 10%. And since the interval from call received to first shock in most EMS systems is north of 10 minutes, you can do the math to see why cardiac arrest survival is so abysmal. In fact, it is a death sentence in much of the world. But by implementing these key strategies, we can bend that line of cardiac arrest survival to achieve a survival rate for bystander witnessed shockable cardiac arrest of 50%. And in fact, in my system, our 5-year rolling average right now for bystander witnessed shockable cardiac arrest is 55%. And that is survival to hospital discharge with good functional capacity. So I'm talking about returning people home to their loved ones, and that's what this is about. So as I said, high performance CPR is from top to bottom in our organization is the expectation of every single employee up to and including the fire chief. This is our fire chief, Brad Tadlock, doing the chest compressions here. And Danielle Tyson, one of our fire inspectors, who is on the airway. So we have one standard across the entire organization, even if responding to actual emergency calls is not their primary responsibility. And we have a very checklist driven now process for resuscitation to make sure that evidence-based care is provided each and every time. We want to deliver a very consistent product. And so if you look at our checklist here, there's actually a front and a back. On the left hand is what we do during the resuscitation. So that's the resuscitation management side. And then once we get a pulse back, we flip the checklist over, and then post-resuscitation care is on the other side. So this isn't a comprehensive treatment of post-resuscitation care today, but I just want to give you guys an idea of why we have standardized post-resuscitation care in our department and why we think that it has provided additional value for cardiac arrest survival. So we're going to be talking primarily about what we do in those moments after that, in about the first 10 minutes after we get a pulse back. So first though, oh, by the way, this is what I call putting a bow on it, okay? Because a lot of times some departments call this the 10-minute timeout. Other people, say, well, they do different things. Other people on Twitter are like, well, show me the evidence that we should take this timeout. Maybe calling it a timeout was a bad idea. Makes it sound like we're sitting there twiddling our thumbs doing nothing. This isn't a timeout. What it means is once you get a pulse back, you need to slow down. And that's a little bit unintuitive for some people. They think you should just go. Patient flapping in the breeze behind you as you fly down the street. Well, when we first started getting pulses back on patient, we tried that and it doesn't work really well. That's an easy way to fumble inside the 10. So now what we call this is putting a bow on it before we transport the patient to make sure everything that we need to do to ensure the patient's safety before we move the patient. So that is the concept here. And we didn't invent it, ourselves. It has a basis in the medical literature. There are certain things that need to happen once you get a pulse back. And so we've just systematized it in a checklisted form that kind of works for us in our department. But first, let's talk about how you know you have ROSC in the first place, because that's not always as simple as you might think. So yes, for the most part, we get a sudden rise in end-tidal CO2. There's no exact number. It's a relative thing, right? So if you're doing high performance CPR and your end-tidal CO2 is 28 and you've just shocked the patient, you're doing your post-shock compressions, and all of a sudden you look over at the monitor and now it's 45, that's a big jump. And so relative to what you were achieving with just high performance CPR. So you think, well, something's different, something's changed. Maybe this patient has a pulse back. Most of the time, you can tell there's an organized rhythm on the monitor and you can see that through the CPR artifact, but we want to confirm that with a pulse check. One of the ways you can do that is to put your fingers on the femoral pulse during chest compressions, and then your fingers are in the right spot. So when you stop CPR to check pulse, you have a much better idea that you're not going to miss it just because we're not very good at pulse checking. I'm not just talking about EMTs and paramedics. I just mean in the house of medicine in general, we're not that awesome at pulse checking. So if you don't have that Doppler wand on your truck or something like that, that's one trick you can do. You can also attach pulse oximetry and look for a pleth waveform. But some of our PEA arrests that we just work over and over and over and over, a lot of times that's a patient that really has ROSC and either their blood pressure is too low or we're not just checking in the right spot. So set yourself up for success, but that's what we want. Sudden rise in end-tidal CO2, organized rhythm on the monitor, confirmed with a pulse check. And then you have ROSC. That's when we basically announce that fact and flip the card over. So here is a histogram, a CO2 histogram at the end of a call. And I've marked it up here so you can see the point at which there was ROSC. So that's basically what this looks like, the sudden rise in end-tidal CO2. And then we want to take our checklist here. So you'll notice the very first box on here is just attach pulse oximetry. Why is this? Because a lot of times when we first have ROSC, especially since we checklisted this, these patients, their SATs aren't that awesome when we first get ROSC. And so the idea here is we want to bring up their sats gingerly without blowing off too much of their CO2. We want to optimize their oxygenation and their ventilation at this point. So if you take a look at this graph, that dotted red line there is when we achieved ROSC. And you can see with the blue arrow, when we first attached pulse oximetry, and in fact, the sats were like low 70s. And then you can see that we very carefully and thoughtfully brought up those sats in those first minutes after ROSC, trying to be careful not to blow off too much CO2. That's very first thing on our checklist, is just how is our patient doing with their oxygenation? And then we want to get a full set of vital signs, because just like you don't fly an airplane without instrumentation, how do we know what's happening with our patient clinically if we don't set ourselves up for success? So if we take a set of vital signs and now we know, okay, patient's respiratory rate maybe is 6. So the patient's trying to breathe. And what we're doing is bringing someone back from the dead. So if you've ever seen this, whether it was a drowning, whether it was a witness VF arrest, a lot of times we brought this patient out of VFib and they're starting to gasp a little bit. This patient's, you know, this brain doesn't want to die. It's starting to try and breathe. And so what we hope is that's going to continue. A lot of times we end up transitioning these patients to a non-rebreather mask and put them in a semi-Fowler's by the time we get to the hospital. So we want to support that. We want to support that patients with their returning airway reflexes. We want to support them with oxygenation. We want to make sure their heart rate is adequate, that we don't need to speed it up. But you know what? We don't want to reach for drugs too soon. We want to oxygenate them and get their heart rate up and things like that. So think about your H's and T's. We want to make sure we've got enough blood pressure, and we're going to watch those sats start to rise. And even though we're not doing rapid infusion of ice saline anymore, we want to check the patient's temperature. So get yourself a full set of vital signs. That takes a few minutes right there if you're doing everything correctly. And we also want to get a 12-lead ECG. And our checklist just says, you know what, capture it and just transmit it to the hospital. So that way, if the cause of this sudden cardiac arrest was, in this instance, LAD occlusion, that's made obvious right away. And we're giving the hospital an early heads up that we have a patient, a witness VF arrest, let's say, with ROSC that is showing STEMI on the ECG, because it's possible they're about to start an elective procedure or something like that, that they can hold up and be like, wait a minute, we've got something coming in. Their need is greater than this elective cath. Okay, so we want to give them early notification there, because a lot of times this is where these patients need to go to reverse the underlying cause of the cardiac arrest. Okay, and we want to make sure that that can happen as seamlessly possible if it can happen. And then we want to also set the VFVT alarm, or on the Zoll monitor, it's called the LTA alarm, or the life-threatening arrhythmia alarm. So if you've never done this on your LifePak or on your Zoll monitor, just remember, these things come with owner manuals, and it goes against everything we believe in to read those manuals. But learn and train your staff how to set those alarms, because what we have found is sometimes these patients rearrest halfway down the sidewalk on the way to the ambulance or on the way to the hospital. One person's back is turned talking on the radio, someone else is troubleshooting the IV while the patient's been in, VF for a minute and a half before anyone recognized it, and that's bad. Okay, so make sure that you set the alarm so that if the patient rearrests, you have early notification so you can defibrillate them right away. And only if they are hyperthermic, which is not impossible on Hilton Head Island. We are a subtropical climate, and our summertime temperatures here can be very, very hot. If we resuscitate somebody on the beach and they are hyperthermic, we will initiate external cooling. And then we're going to reevaluate the airway. Now, this does not mean that we're going to rush to throwing in an advanced airway. Many of our patients are resuscitated with a bag valve mask, a pair of hands, and a defibrillator. We're a department that practices and believes in expertly performed BLS as the core evidence-based strategy to resuscitate these patients, particularly our shockable cardiac arrest. So when I say reevaluate airway, what I mean is, how effective is our compliance? Are we getting good ventilations? Does the patient need to be suctioned? If they have return of airway reflexes, which often they do, are they choking on their OPA? Should we remove that? So the concept here is, if we can have a conscious talking patient by arrival in the emergency department, we ought to let that happen. A lot of people are like, well, no, okay, we won't intubate during chest compressions because we don't want to interrupt compressions. So we'll just intubate once there's ROSC. Okay, so then you do that, but then your patient's airway reflexes start to come back. So then what? Well, let's medicate the patient to facilitate the tube, okay, which confounds the neuro exam. So now the neuro outcome is uncertain, and this patient's going to be getting targeted temperature management. And now perhaps the invasive cardiologist wants to let that play out before they take the patient to the cardiac cath lab. It has all these downstream effects. There is no better outcome than somebody sitting up, having a conversation with you by arrival in the emergency department. So if it can happen, let it happen. It doesn't always happen. It can't always happen. Yes, some patients need advanced airway management, but whenever possible, we want to allow that patient's airway reflexes to return. And then we obtain the patient's name, age, and ask whether or not they have a preferred cardiologist. Why is this? Because this is Dr. McSleepy, and it's 3 o'clock Sunday morning. And if we wake him up to do a cath and it turns out that the patient wanted a different cardiologist, it makes Dr. McSleepy very sad. And so I'm just poking a little bit of fun here, but this is what I mean by putting a bow on it. Okay, we want to do everything that we can to make it as easy as possible for downstream providers to do the right thing and do their part to provide this evidence-based care. Because ROSC is only not even maybe a halfway point. It's the part that EMS was responsible for. Now we have to transition them into in-hospital care, and everybody has a role to play. And then finally, we assemble an appropriate team to transport the patient, and we stipulate we want at least 3 in the back. Why? Because if the patient rearrests on the way to the hospital, we want to be able to pull over on the side of the road and re-implement high-performance CPR. And so this doesn't even need to be on our checklist anymore. It's been a long time on Hilton Head before we had any problems. But just like Dr. McSleepy likes his sleep, so does Captain Smokey, okay? One of these old school firefighters. In my career, I've been a fireman for 22.5 years. I've really seen us turn the corner from old school to modern, progressive, fire-based EMS system. So there's not many of these guys left, but there were always sometimes that fire captain at 3 in the morning that would be like, you guys got it? I mean, they're not in cardiac arrest anymore, so why shouldn't you be in the back by yourself with this patient with ROSC? So we just made it very clear what our expectation is. It's not that we ever wanted Captain Smokey in the back of the ambulance. We wanted the guy, well, one of these guys that was probably the nozzle firefighter, one of these young, enthusiastic young fellows who is the future of the fire service, help riding that in. But that means then that Captain Smokey needs to follow the ambulance with the engine up to the hospital to retrieve their personnel. So again, this is just something in there so that everyone understands our expectation. We follow things through all the way to the goal line and make sure that our patient arrives as safely as possible to the hospital. And that we have a good handoff and that we've built up a lot of trust. So here's a picture right here of some of our staff taking a patient that had ROSC straight to the cardiac cath lab table, bypassing the emergency department completely. This is one of our survivors here. And let's see how I'm doing on time, right around 11:30. So if you have any questions, I'll be happy to answer them. Again, Floyd, thank you so much for inviting me. Appreciate this event. Hope everyone's having a great day. Thanks for all that you do. And I hope that you and your families are all staying safe during this global pandemic. Thank you very, very much.
Hey, Tom, we ran over a little bit on the last lecture, so if you need to keep going, feel free to.
No, I'd like to try and keep your day on track here. I had a little overflow material depending on time, but I think this is just as good a place to stop as any, Floyd. So I don't know if there's any questions in queue. If there are, I'd be happy to answer them. If not, then hopefully we'll be back on track.
I don't see any questions. Does anybody have any questions for Tom? If so, please use the Q&A section.
Awesome. Thanks, everybody.
Thanks, Tom.
Appreciate it.